Hello, and thank you for inviting me to give this talk about management of refractory non-Hodgkin lymphoma. I am Dr. Maadh Aldouri, a hematology consultant at Medway Maritime Hospital in Kent and King's College Hospital in London, and I'm also the clinical director of pathology for North Kent Pathology Service. The outline of my talk will be to review the relapse rate of some of the common lymphomas. I don't really have time to go through all types of lymphoma, but I will explain, I will emphasize on the common types of lymphoma. What current recommended standard salvage therapy we have to use. When do we consider choosing hematopoietic stem cell transplant, autologous or allogeneic? I'll discuss some of the new monoclonal antibody therapy which has come in use over the last few years, and also the introduction of CAR T therapy, which has basically really changed the management of many types of lymphoma and has been in routine standard use now in the UK for the past 4 or 5 years, and also to go over some new targeted molecular therapy. So most of the lymphomas, the most common type of lymphoma is the diffuse large B-cell lymphoma, about 1/3, and follicular lymphoma, another quarter of lymphomas, and marginal zone lymphoma in addition, which is about 8-10% of cases. Mantle cell lymphoma always poses challenges in management because of the heterogeneity of this condition and the severe course of some of them. And then there are the rare types like the mediastinal large B-cell lymphoma and the T lymphoblastic lymphoma and anaplastic large cell lymphoma. So let's focus on the follicular lymphoma and marginal zone lymphoma first, which are obviously low-grade lymphomas, which are indolent in nature as lymphoproliferative disorders, and they constitute about 1/3, 1/4 to 1/3 of all NHL cases. Patients may present with asymptomatic lymphadenopathy, usually bone marrow involvement in the majority of cases, and the presentation can take many years. Marginal zone lymphoma is less prevalent than follicular lymphoma, in the region of 10% or so, and can be either extranodal, splenic, or nodal. So many of these low-grade lymphomas, follicular marginal zone lymphoma, may be monitored and observed only. But if we do need to treat for good reason, like bulky disease or affection of vital organs, then we can use either radiotherapy or immunochemotherapy at the beginning, especially in the early stages of the lymphoma. And in general, we have a good outcome. 5 years of overall survival is in the region of 75%, and majority of them will live 18 to 20 years after diagnosis. However, if there is progression of disease within 24 months, and in this subset of patients, then the outcome is not usually as good as the others who respond well, and the overall survival may be cut down. The 5-year survival may come down to 50%. But there are effective therapies for second line and beyond, which we'd like to review. The first-line therapy may include antibiotics, sometimes for marginal zone lymphoma, especially of the stomach, for example. We may treat for antibiotics like the triple therapy for Helicobacter. If it's localized, we may use radiotherapy. And if it is more bulky and further stages, then we may use immunochemotherapy. Effective therapy for second line and beyond for those who relapse is also available. But it's important to, and I'll review that in the next few slides, it's important to have an idea about how to sequence the therapy and how to move on with the treatment depending on the presentation and the organ function, and to avoid toxicity, giving the usually non-curative nature of this condition. So what are the treatment options for relapsed follicular lymphoma? At the moment, when we do need to treat follicular lymphoma in the UK, most of us are using a combination of immunotherapy, usually obinutuzumab, less rarely rituximab, in addition to CVP, cyclophosphamide, vincristine, prednisolone, and previously bendamustine, but most of the time we are using OCVP as a first-line therapy. So The outcomes are usually very favorable with a very good response, and this is followed by maintenance with the antibody obinutuzumab or rituximab every 8 weeks for 2 years. Progression-free survival at 10 years after R-CHOP is very good and exceeds 40%. Median overall survival, as I said, exceeds 20 years. But now we have more understanding of the clonal nature of it and the heterogeneity on follicular lymphoma, which may bring some precision medicine into the role so that they can treat these conditions. In general, when we are dealing with a relapsed follicular lymphoma, we advise a repeat PET-CT scan to stage the condition and to perform excisional lymph node biopsy or true-cut biopsy from the lymph node, which shows the highest level of FDG uptake in order to decide whether we are dealing with transformation of follicular lymphoma or whether it is still low grade. And then we need to consider presence or absence of symptoms, the pace of relapse, time of relapse, type of therapy, age, comorbidities, and the goal of care. What are we aiming to achieve with this particular patient? It needs to be individually tailored for the needs of the patient we are dealing with. This is a large study, almost 600 patients, the LymphoCare study, NLCS, and it showed that those who respond well to treatment and maintain their response for 2 years, then they have 80% chance of long-term survival, more than 5 years. However, those who relapse within 2 years and the progress within 2 years, their outcome is not so good. As I mentioned, about 40% long-term survival. And earlier relapse associated with high mortality follicular lymphoma. These are 2 other studies from Canada, and shows also that about 80% overall progression-free survival, those who respond well, and down to 30% to the non-responders, and the same here. Early relapse associated with high mortality. This is the Mayo data, Mayo Clinic data, and again you can see those who do not achieve event-free survival in 12 months. They relapse quickly, and when they relapse, then their overall survival is just over 40% in 10 years' time. While those who achieve good response and progression-free survival for 12 months, they maintain almost 80% 10-year survival. This is the German and the Canadian data, which I showed earlier. So the gallium subset, the gallium study used obinutuzumab with other chemotherapy like bendamustine or COP, and it showed that PET-CT is a good predictor of survival. Those who are PET negative did well, almost 80% overall survival, progression-free survival, while those who are PET negative, PET positive, relapsed quickly, and their survival was in the region of their progression-free survival was in the region, the median was in the region of 50%. Current treatment out guidelines for refractory or relapsed follicular lymphoma. It depends what we started with. So if we start with CVP, then we can go for obinutuzumab or rituximab, bendamustine, or indeed adding CHOP to the instead of COP. And if the patient is not fit for chemotherapy, then lenalidomide rituximab, which we actually label here as R square, is a very good option in giving us good response for the relapse or refractory lymphoma using immunotherapy without the use of chemotherapy. Other options include Zevlin, which is a radioactive type of anti-CD20, lenalidomide alone, or lenalidomide with obinutuzumab and rituximab. And then for third line or beyond, we can consider the use of PI3K inhibitors such as Idelalisib or other derivatives. Idelalisib and Duvelisib are oral medication, where Copanlisib is IV medication. More recently, there are trials in using EZH2 inhibitor, such as tazemetostat, to treat these cases. And more commonly here in the UK, we are using anti-CD19 CAR T-cell therapy when the patient fails 2 lines of treatment of systemic therapy. So that is what we are doing for a lot of the patients who are fit enough to and comply with the criteria to go for CAR T therapy, and I'll explain about that later on. AUGMENT trial compared lenalidomide rituximab with rituximab and placebo in this number of patients, almost 360 patients, and it showed advantage and significant benefit from combining lenalidomide rituximab versus rituximab alone in the probability of progression-free survival or probability of overall survival. There is still advantage for lenalidomide rituximab versus rituximab. The rituximab is given for 6 months, followed by continuous treatment with lenalidomide afterwards. For those who respond, is what we do at the moment for relapsed follicular lymphoma. And this study, the CALB study, compared lenalidomide rituximab to lenalidomide alone, as opposed to rituximab in the AUGMENT study, and again showed advantage of combining lenalidomide rituximab to lenalidomide alone in this group of patients in this trial. Gathering is another study which looked at combining bendamustine or bentuzumab versus bendamustine, and again the immunochemotherapy showed advantage in overall survival and significant difference, almost 70%, 5-year survival compared to 40% for the chemotherapy arm alone. Idelalisib remains an option for the 3rd line and beyond, as I mentioned earlier. It's an oral medication, which is PI3K gamma inhibitor. PI3K delta inhibitor. It's a single-arm phase study of idelalisib showed good response in a number of low-grade lymphomas, follicular lymphoma, smaller lymphocytic marginal zone lymphoma, and LPL. And it is approved for relapsed follicular lymphoma. We have to be very mindful of the possible toxicity, such as neutropenia, elevation of liver enzymes, and mostly colitis-like picture and GI symptoms, which has been limiting the use of idelalisib in other areas, as well as the increased chance of opportunistic infections. So we have to be careful about these complications. So considering PI3K inhibitors, all the idelalisib and the other medication I mentioned are all approved. We have different toxicity profile, which may help us to decide which one to use in particular patient. Hepatic toxicity, immune-related colitis, most common in idelalisib, and duvelisib, war hyperglycemia and hypertension with copanlisib. As I said, copanlisib is IV and the 2 others are oral. So this scheme will help us to understand the algorithm for treating low-grade lymphoma. If they have a follicular lymphoma, if there is low tumor burden, stage 1 or 2, we may watch and wait, or we may use involved radiotherapy or rituximab immunotherapy alone. If there is progression, and this is stage 3 or 4, we can either watch and wait in the low tumor burden, or we can use immunochemotherapy or radioimmunotherapy. For the high tumor burden, stage 3 and 4, for the younger patients, we can go for salvage treatment, immunochemotherapy, and sometimes only rituximab immunotherapy, followed by autologous stem cell transplant, or we can go for rituximab and lenalidomide, as I showed earlier, and then you can follow that by maintenance treatment with immunotherapy or continuing with lenalidomide. Very, very rarely we have young patients who may be selected for allogeneic stem cell transplant if they are fit enough for that option. For the older patients, again, we go for immunochemotherapy in order to get them into response and remission. And we can follow that by immune therapy for a maintenance treatment, or we can consider the use of CAR T therapy. Marginal zone lymphoma, pretty similar in its behavior, and if a patient relapses, then you can consider similar options to the follicular lymphoma like CHOP, rituximab, CVP rituximab, bendamustine rituximab, or indeed lenalidomide rituximab. Ibrutinib can be considered as well and would be effective in marginal zone lymphoma, or we can go for the PI3K inhibitors again, or immunochemotherapy as previously outlined in the follicular lymphoma. So for the marginal zone lymphoma, asymptomatic patients may be observed. If systemic treatment is required, then chemotherapy can be contemplated. Autologous transplant is very rarely, but may be considered in fit patients with clinically aggressive relapse. Aggressive is very important. If it's not aggressive, then we would lead them for maintenance treatment or monitoring. And ibrutinib single agent therapy showed anti-lymphoma activity in marginal zone lymphoma, including the nodal type marginal zone lymphoma. What about the role of transplant for refractory and relapsed follicular lymphoma? This is registry data, retrospective analysis of patient follicular lymphoma who received myeloablative therapy, cyclophosphamide and TBI, followed by autologous stem cell transplant, and really gave a very good 50% remission of that cohort. 16 patients relapsed and 15 mortality for a number of 121. So it's around 50% overall survival. But you can see that there is still a high rate of relapse among these patients, and not insignificant mortality because of secondary malignancy, MDS and AML. And the apparent progression-free survival was around 50%, 48% over 12 years. And this is, again, registry data comparing stem cell transplant cohort versus non-transplant, showing advantage survival advantage for the transplant arm. Canadian and German data showing similar findings of advantage in overall survival for the stem cell transplant, around 70% versus 40% for non-transplant, and 50% versus 40% for the non-transplant in the German cohort. Recent key themes in the transformed follicular lymphoma. It's, as I said, it's important to do a biopsy to make sure we are not dealing with transformed follicular lymphoma, and they remain an important cause of morbidity in this group of patients. Histological transformation may be decreasing in the rituximab era as we use maintenance as well. But heterogeneity of mutations have different outcome. For example, we may have double hit germ cell type B-cell lymphoma, which tend to do worse. Improved outcome for transformed follicular lymphoma, that's significant overall survival overall. So for the transformed follicular lymphoma, there is no role for really watch and wait. If we have a suspicion of a high-grade transformation, then we would carry out of FDG PET CT scan, biopsy the site with the highest SUV, and then if the confirmed transformation is there, older patients can be treated with lenalidomide rituximab or R-CHOP, preferably R-CHOP, if they are fit for that, and then consolidation with radioimmunotherapy. If they are young and fit, then and they're anthracycline naive, then we go for R-CHOP. If not, then we go for second-line salvage chemotherapy, usually cisplatin based, followed by autologous stem cell transplant, or consider stem cell transplant there as well. In addition to nowadays, we need to add the CAR T therapy option for these patients and even that patient as well. So summary of the refractory lymphoma with early progression of disease. Best management approach is still unclear. We have multiple options of lenalidomide immunotherapy, lenalidomide rituximab versus chemoimmunotherapy such as obinutuzumab bendamustine or rituximab bendamustine versus PI3K inhibitor, followed probably by high dose therapy and stem cell transplant if appropriate. And the UK, lenalidomide and rituximab is certainly approved and funded for previously treated follicular lymphoma, and PI3K inhibitor also a relapse for follicular lymphoma beyond 3 previous treatments. And obinutuzumab is emerging to be the antibody of choice, the CD20 antibody of choice, rather than for those of rituximab refractory or relapsed disease. And high-dose therapy plus autologous stem cell transplant should be considered for the correct patients. Moving forward, the outcome for follicular lymphoma has certainly improved significantly with immunochemotherapy and maintenance. The overall survival is exceeding 20 years. Subset of patients with poor outcome identified clinically by early disease progression. A rationally defined novel targeted therapy will include PI3K inhibitors, lenalidomide, immunomodulators, EZH2 inhibitors, and CAR T-cell therapy. Let's move on to the other very common type of lymphoma, which is diffuse large B-cell lymphoma and primary mediastinal B-cell lymphoma, and how do we deal with the relapsed refractory cases. So in general, we are still getting good response to those. The standard treatment in most of these is R-CHOP. For the mediastinal lymphoma, we are increasingly using escalated EPOCH for the treatment. But when they relapse, the patient who relapse, then the outcome is pretty poor, having received chemoimmunotherapy to start with. And when they relapse, the response, complete response, is pretty low, around 7%, and only a quarter of them will have objective response. So on the whole, the outcome is not very good for the relapse or the refractory patients with diffuse large B-cell lymphoma to first-line treatment with R-CHOP. There are different strategies to deal with these patients who are relapsed and refractory diffuse large B-cell lymphoma, and progression occurs at median 7 months after autologous stem cell transplant in some patients. If they relapse, then their survival is going to be short. I mean, we do offer second-line salvage therapy, and we do offer stem cell transplant. If they relapse in spite of that, then their outcome is going to be very poor, and the overall survival is less than 6 months if they relapse following a transplant. Allogeneic transplant is an option for the young ones, but the treatment-related mortality is very high, around 28%. Only a small number of them are going to be eligible for that option anyway. And patients who are refractory to second line, 40% will not obtain objective response at second line. This is the problem, whatever you do. And then you become secondary refractory. So no standard approach for the primary mediastinal B-cell lymphoma. And when they relapse, it's about this is where your best option is to get the best possible outcome for the initial treatment with R-CHOP or dose-adjusted EPOCH, followed by radiotherapy if required. If they relapse, then 40% survival after 3 years. This is a schema of how we manage most young patients who relapse or refractory for R-CHOP and diffuse large B-cell lymphoma. This study randomized R-ICE 3 times, 3 courses versus R-DHAP, followed by beam autologous transplant, and then either maintenance or observation. And the overall response from first randomization was pretty similar, about 48%, about half of them had a good response, and there was no observed benefit from maintenance afterwards. So R-ICE and R-DHAP give similar outcome result for relapse or refractory diffuse large B-cell lymphoma, and there is no advantage of following that by maintenance treatment. A new anti-monoclonal antibody have been using now for the last couple of years is polatuzumab vedotin, which is a CD19, CD79B monoclonal antibody. It's a CD79B monoclonal antibody with drug conjugate, and it's been now used routinely in treatment in combination with bendamustine and rituximab. So we have the advantage of two immunotherapies, polatuzumab, rituximab, in addition to chemotherapy with bendamustine, giving us really very good overall response in these cases of more than 50%. This trial compared Pola BR versus BR. So BR has been standard for relapsed diffuse large B-cell lymphoma for some time, and compared to adding Pola BR showed very good outcome. There were 40 patients in each arm, and as you see, the response was almost 30% in the Pola BR versus the time in months, 2 years versus almost nothing in the BR. So they all relapsed. While here we have a cohort of patients who had ongoing relapse. So Pola BR became quite an effective treatment, and overall survival was over significantly better, as we have seen with the progression-free survival in the previous slide. So the overall survival was in the region of 40% with Pola BR versus 20% for 2 years in BR alone. And that this study, apologies, is not very clear writing in it, but you can see the idea here. Pola BR gave better progression-free survival and overall survival in both activated B cell and germline cell B type here, and in the for the progression-free survival and for the overall survival. Polatuzumab can be used as a salvage treatment, as I have shown in the previous slide, as well as bridging. It could be used for bridging chemotherapy to give around 2 cycles for patients who relapsed following treatment for diffuse large B-cell lymphoma, and then they move to CAR T therapy. So we use it here as a bridging therapy between relapse and getting them ready for the CAR T cell therapy. And when we do that, almost half of the patients manage to reach CAR T therapy to receive further treatment. So the diagram here summarizes what I've just said. Relapsed refractory diffuse large B-cell lymphoma. If they are transplant eligible, then we would use cisplatin-based therapy, DHAP, ESHAP, GDP, or ICE instead of that. If we have a metabolic response, we go for autologous transplant for the younger and fit patients. If they are not, then we have additional salvage therapy or targeted therapy. If they are not transplant eligible and they have adequate performance status and they fulfill the criteria to consider CAR T therapy, then we use axi-cell usually here to prepare for CAR T cell therapy. If not, then you go for other options of targeted therapy, such as the tafasitamab, which is another immunotherapy with lenalidomide, anti-CD19, and other options of polatuzumab, CD79, B, and bendamustine and rituximab, as I said, all selinexor, or the option of selinexor, which I will talk about in a few minutes. These are the salvage induction therapy. I mentioned RIs and RDHAP and GDP. GDP has been easier to administer, and the outcome is pretty similar between these arms. And nowadays in the UK, we use mostly RGDP rather than RDHAP or ICE, RIs. And as you can see, the response rate and the transplant is pretty similar and the progression-free survival are pretty similar between these options. Now, this diagram shows an increasing number of molecular targets that we can aim for to treat with the JAK2 mutation, with the histone deacetylase inhibitors, EZH2 inhibitors, CMYC, and so on, BCL2. We have XPO1 inhibitors as well, PI3K inhibitors, as we said with Idelalisib. So these molecular targets are getting increasingly identified. We have the Bruton kinase with a Brutinib option here, and so on. So these targets are being used in trials, and some of them have gone into phase 2 and 3 and beyond, and some of them has gone into a routine practice. So the PI3K inhibitors already, as we know, has been approved for use in a treatment of refractory diffuse large B-cell lymphoma. MTOR inhibitors, everolimus, temsirolimus, is also used, usually sometimes in combination with lenalidomide, rituximab, or DHAP in these trials. BCL2 inhibitor, venetoclax, in combination with lenalidomide, RICE, dose-adjusted EPOCH, or obinutuzumab, rituximab, polatuzumab, as we have seen earlier. BTK inhibitors, Bruton kinase inhibitor, Brutinib, again in combination with other agents. Immune modulator, lenalidomide with CHOP usually. EZH2 inhibitors, tazemetostat and valemetostat are used in these trials, and histone deacetylase inhibitors. SKB1 inhibitors, selinexor, is also been used in combination with R-CHOP and R-ICE. So these targeted therapy are increasingly now being used in trials, and this is to space how we get the next line of treatment for these patients. Diffuse large B-cell lymphoma standard treatment is usually R-CHOP. Almost 2/3 will be cured. A third will relapse. If they are transplant candidates, we give second line, I said RGDP or other options like RICE. If they respond, they're PET negative, then we go for auto transplant, more rarely allotransplant. And then many of them, almost half of them, 45%, is going to be cured with that. If they relapse and they are refractory and they're not candidates for transplant, we go for second line therapy, which can include, or if they did have this arm and they remain PET positive, then we can go for CAR T-cell therapy, followed by sometimes allotransplants, or the use of targeted therapy like selinexor, or an antibody treatment in addition to lenalidomide, or enter into clinical trial. And pola-BR remains a good option, a salvage therapy for the refractory relapse patients. So what is CAR T therapy? And this is the last part of my talk. CAR T stands for chimeric antigen receptor T cells that are modified to express the CAR complex. So these T cells of the patients are modified with the genetic signaling in order to have T cell toxicity against the patient's tumor. How are the CAR T cell made? We carry out apheresis of the patient. We isolate the T cells from the patient, and then they become activated and transformed to cytotoxic T cells. A gene is inserted using a virus that causes the CAR T to be expressed by the T cells. Then the cells are expanded, and this process takes about 3 to 4 weeks. After that, the cells are either purified, well, they'll be purified and either frozen, or they can be freshly infused into the patient in order to treat the tumor. And with these patients, we do not need to have the patient in a good remission or responsive state. They can still be in relapse when they receive the CAR T therapy. So there's a T cell activation domain, or there's a co-stimulatory domain, and then the variant, the light and heavy chain areas of the antibody, of the receptor. And then they will be transcribed to the CAR expressing T cells in order to attack, in this case, diffuse large B-cell lymphoma cells. So in the first instance, we construct a CAR gene, which is in our case with diffuse large B-cell lymphoma is a CD19 gene. Second, we insert that CAR gene into the retrovirus vector. And then these cells are transduced into the T cells and expanded ex vivo. We have isolated the cells from the patient and put them there to expand the cells, get them to contain the CAR T cell that is going to attack the CD19, and then these cells are reinfused into the patient. The cells are apheresed, and then the patient is going to receive the lymphocyte depleted chemotherapy, and then the CD19 CAR cells are returned to the patients. And this ex vivo processing is the T cell activation, transduction with the gamma retroviral vector encoding the CAR gene, and then T cell proliferation. So we take the cells, we carry out this procedure, and then we reinfuse back to the patient. The types of CAR T cells, they are different according to the specific surface protein, so they'll be targeted according to what cancer we are treating, and the targeted protein must not be also expressed somewhere in the body that could cause harm. The target surfaces examples are here. So if you're treating Hodgkin lymphoma, our target protein is going to be CD30. For diffuse large B-cell lymphoma ALL, it's going to be CD19. For multiple myeloma, it's LAMF7, and for multiple myeloma, could be also BCMA. So CAR T therapy for myeloma has not started as a routine treatment in the UK now, but trials are very much in progress. But we're certainly using it to treat lymphoma and ALL, and also treating mantle cell lymphoma at present. The protocol designed for CAR T treatment is to give 3 days of chemotherapy with fludarabine and cyclophosphamide from days -5 to -3, and then to have a couple of days of washout, followed by infusion of the CAR T transduced T cells. And this chemotherapy is given in the day hospital. And these are the doses of cyclophosphamide and fludarabine. However, we have to be mindful that CAR T treatment is really associated with severe toxicities, mainly the cytokine release syndrome, which is very common to happen after CAR T therapy and can be similar to infection with high fever, tachycardia, hypoxia, hypotension. There is impairment of the liver and kidney, prolongation of coagulation profile, and sometimes patients require to have ICU admission, and that happened in the first 2 weeks after the infusion. In addition to that, the main other toxicity after we pass the cytokine release syndrome is to go through neurological toxicity with confusion, somnolence, tremors, gait instability, aphasia, seizures, neurologic toxicity, and these can happen to up to 4 weeks from the infusion of the CAR T cells. So these are the important toxicities. I mentioned the constitution and the cytokine release syndrome that can also lead over to skin, GI, respiratory, cardiovascular, coagulation, and so on. So they're quite significant symptoms that we have to deal with. And they are more common in things like in diseases of ALL other than non-Hodgkin lymphoma, and when there is bone marrow involvement and high burden of disease, and when you are using fludarabine for the lymphodepletion, and when you have a high cell dose of T cells back to the patient. The management of this toxicity will be symptomatic with anti-inflammatories and antipyretic agent, cardiovascular monitoring and intravenous fluid, monitoring carefully for things like troponin, echocardiogram, and so on. Infection disease control and make sure we are not dealing with any infective episodes, allopurinol transfusion and blood support, correction of coagulation abnormality, and neurological monitoring and observation of these patients, carrying out MRI if required. So the patient experience these toxicity. It could be neurological or chronic or cytokine release syndrome. And these are the measures I outlined in the previous slides. We can even use antibody treatment like tocilizumab, interleukin 6, if the symptoms are significant. Otherwise, we continue supportive treatment. We have been moving to outpatient management post-CAR T cells, but there is need for frequent visits and need for frequent lab investigations. We can give GCSF. There is cytopenia for neutropenia, and transfusion are required. And even when they are discharged, we do not let them go further from the hospital. So they're usually staying in residency or hotels very near to the hospital so that they can attend frequently, and they are going to be managed accordingly if they require urgent admission. So who is eligible to be treated for the CAR T treatment? They must have type of cancer that CAR T cell target exists. So we need to have an effective CAR T cell target, CD19 in the case of diffuse large B-cell lymphoma. A progression of relapse disease through standard therapy, they need to show that they have been progressed, and they have to have measurable disease. There is a panel in the UK which discusses every single patient who needs to be approved for CAR T therapy. And where I work at King College Hospital, there is a very well and good and experienced team for CAR T therapy that has been going on for the last few years. The patient cancer must express the targeted surface protein and be able to tolerate apheresis with a reasonable performance state and good organ function. And we very frequently, they have the panel and the team will request evidence of disease and may probably repeat the biopsy for these patients. The timing of the treatment needs to be considered. The apheresis unit is getting increasingly busy with the requirement because of the load for autologous transplant for things like myeloma and lymphoma, and now for the CAR T therapy. We have to maintain regular contact with the main oncologist, the referring oncologist, and then we have to consider the social aspect of it. It's a very costly experience to go through and being off work as well. Sometimes carers have got to give support as well. And as I said, we keep the patients in vicinity of the hospital to make sure we can deal with their complications. CD19 expression is restricted to B cells and possibly follicular dendritic cells. It is not expressed in the pluripotent bone or stem cells, so that's why the CAR T cells triggered against CD19 are not going to be attacking the stem cell, and it's expressed on the surface of B cell malignancies. So the CAR T cell targets will be CD19 in B-ALL and lymphoma. It's CD22 in diffuse large B-cell lymphoma and B-ALL as well, and some and non-Hodgkin lymphoma. So we have another target there. CD20 for CD20 positive malignancies, ROR1 for CLL and SLL, and so on. CD30, as I said, for Hodgkin lymphoma, CD123 and CD33, and these ones we use for these three for acute myeloid leukemia, and these two for multiple myeloma. So we have different targets that these cytotoxic T cells can be transfected with. And the process, as I have already explained, so I'm going to pass the slide. These are the FDA-approved CD19 targeted CAR T cell therapies. The one we use most commonly is the Axicell, we call it, which is used for refractory and relapsed large B-cell lymphoma after 2 lines of systemic therapy. Then we have the brixapathogen autoleucel adults with refractory mantle cell lymphoma, and this has started as a standard treatment over the past 6 months. Lysomal muscle cell for refractory B-cell lymphoma as well, and tisagenlecel is another one for diffuse large B-cell lymphoma. And these are the outcome. These are the 4 agents I have mentioned in the previous slides. and the number of doses of cell that we require for each of them. They all target CD19 in their efficient activity, and they're all approved for lymphoma, and this one is approved for the mantle cell lymphoma, for mantle cell lymphoma. These are the pivotal trials which showed the efficacy of these agents. The Axicell Zuma 1 trial was one of the earlier trials which showed the benefit and of this treatment in the diffuse large B-cell lymphoma population of patients. And you can see here that almost 45%, almost 40% overall survival and 40% progression-free survival for the Axicell and the Zuma 1 style. In the Julia trial of Tisectinib, again, similar results, and the same thing here for the Transcend trial. So all they're giving about 40% overall survival and progression-free survival. And with the cytokine release syndrome being a very common toxicity, almost 60% in the Julia trial, 90+% here, and 42% there in the Transcend trial. And a grade more than 3 is quite significant as well, 12%, 28%, and 10%. This is for neurotoxicity as well as the high incidence of toxicity for the cytokine release syndrome. So just go a few slides on the Zuma pivotal trial, and the study design was for the relapsed diffuse large B-cell lymphoma, and as a single arm, there were 7 patients in phase 1, then 2 patients, in phase 2, 101 patients were included, and this is the criteria of the patient included: diffuse large B-cell lymphoma, primary distal B-cell lymphoma, and altogether 101 patients. And the overall response rate in the Zuma trial was 82% for diffuse large B-cell lymphoma, 83% primary mediastinal lymphoma, and the complete response was 49%, 71% for the mediastinal lymphoma, and overall about 54% response rate. So leukapheresis followed by CAR T manufacturing, then as I said, 3 days of chemotherapy, 2 days break, and then infusion, and then monitoring. The adverse reactions were similar to what I had outlined earlier, so we'll skip that. Encephalopathy happened about 22%, and there were infections in about 16% of patients. Encephalopathy in this cohort was in the region of 31%, and infections about 19%. Cytokine release syndrome happens in the first 2 weeks, and neurological toxicity can go up to 4 weeks. Median usual duration is about 2 weeks. And in conclusion, with a median follow-up of almost 39 months, patients continue to benefit from Axicell treatment, Yescarta. Overall survival, overall response was 83%. 50% were still alive at 2 years, and median duration of complete remission was not reached. And 93% still have ongoing response at 12 months, and they remain in response. So those who had response at 12 months remained at response on 24 months. Cytokine release syndrome, neurological toxicity was the main side effect, but they were manageable with the defined protocols. The resolution rate was 98%. Late onset of adverse events were largely manageable infections. They were not related to the cytokine release or neurological toxicity. Evidence of B-cell recovery and increased detectable gene-marked CAR T cells suggest that functional CAR T cell persistence may not be required for long-term remission. So they maintain the remission even without the presence of the gene that was transferred with the CAR T cells. Now, with more than 500 patients worldwide data, it remains an effective treatment, and the one that we use for managing relapsed lymphomas, diffuse large follicular or mantle cell lymphoma. A few words about selinexor, which is an XPO1 inhibitor. It's a selective inhibitor for this nuclear export sign. Interferes with the protein known to play a clinical role in diffuse large B-cell lymphoma, and reduces MYC, BCL2, and BCL6. And using this treatment in both types of lymphoma had showed very good efficacy in the region of 34% and 21% in the in the ABC type of lymphoma. So still get a good response, and it's very difficult multi-relapsed patients using selinexor in this trial. Tafasitamab is a new anti-CD19 antibody, which is being used in combination with lenalidomide with good outcome. And in these patients, in this study, the response rate was in the region of 60%, and the complete remission was 42%. So tafasitamab with lenalidomide is another effective treatment. This is obviously going to replacing rituximab in combination with lenalidomide for the study, with giving us very good overall response in this population of patients. So here we are. This is a quite short schema of how we treat relapsed refractory diffuse large B-cell lymphoma. And when they relapse after the first line, usually I said R-CHOP, 60% are going to be cured. Those who are going to relapse, probably 50% will be transplant eligible, 50% are not transplant eligible. So we try to go the transplant route with salvage therapy and transplant and maintain cure about 25% of what we started with. But those who are not eligible for transplant can have second line with the anti-CD19 antibody, tafasitamab and lenalidomide. Or they can have third line therapy with CAR T cells. Bridging can be with pertuzumab and BR, or as a salvage therapy, or the selinexor treatment, or indeed best supportive care. Apart from that, then we go into investigational agents and trials. In conclusion, outcome of treatments of lymphoma greatly improved with combination of immunochemotherapy. 25 to 40% of lymphomas may prove to be refractory or relapse within 2 years. Effective salvage therapy may be followed by autologous stem cell transplant, allogeneic stem cell transplant, or CAR T therapy. New monoclonal antibodies and targeted molecular therapies have been approved or undergoing clinical trials. Many of them seem to improve the outcome of this difficult cohort of patients.